Hey, it's Dr. Modi from Gastro Office. Today I want to talk about a sensitive topic, something called rectal incontinence, or having accidents or soiling yourself. Now, this is an easy topic to talk about if you're a patient with your loved ones or even a GI doc. And so, when we start the conversation, I talk about a couple of things. Most importantly is to get a very thorough history. We want to make sure that there aren't certain specific food types. Maybe it's a lactose intolerance or sugary sodas or, really sweet, desserts that you're having all the time that is resulting in some of these episodes or accidents. The next thing is to talk about, your fiber intake. Are you getting enough fiber throughout the day to help bulk up that stool? And what have you tried? Have you tried Imodium over the counter? Has your primary doctor prescribed Lamodal or any other anti-diarrheal medications? Other workup when I think about incontinence is, do we need to do a colonoscopy? Make sure that there's no inflammation such as Crohn's or ulcerative colitis. We can take biopsies to rule out underlying inflammation under the microscope called microscopic colitis. And then obviously you want to get less invasive testing too. Check for infections of the GI tract that can be treated. Even celiac disease sometimes can cause, diarrhea or loose stool. So all of those things are really important, for incontinence. Now, what I find with a lot of patients is that we just haven't titrated the fiber well enough, quite honestly. I think targeting 30 grams of fiber, whether that's through dietary or supplement, such as Benefiber, Citrusol, is really important. So that's the first and foremost step with, dealing with incontinence. Now, let's say we do all of that workup, nothing comes back. Then I think we have to go digging a little deeper into especially the structural and the anatomical reasons for incontinence. One of them is called just, weak, external and internal sphincter muscle strength. And so here's a picture. This is kind of a cross-section cut. You can see at the bottom, this is your internal external sphincter. And so if they aren't closing with enough tightness, that's something that we need to assess. And the way that we do that is we can do manometry testing. And if you take a look at another video with constipation manometry explains the testing, but essentially we are able to measure that squeeze pressure factor that you may have. And if it's weak, we would actually bring you back to the office and do something called biofeedback therapy, where we work on squeezing that anal sphincter, right? So that's something that's really important also to consider, because as we get older, some of these pelvic floor muscles may not be engaging as well as they should. Now, let's say you go through the manometry and we aren't able to improve that strength. The last thing that we do, and I think it's very unique to our practice, is something called, we can do a sacral neuromodulation trial. So, the nerves from the anal canal need to go back up to the brainstem and vice versa to communicate to say, hey, we need to have tighter control. We can actually implant a test trial, so it'll be a 5-day trial where we're able to implant a device that will send, increased frequency of nerve signals to the anal canal to tell it to squeeze tighter or less, and you will have control with that using a button. Now, if, let's say for 5 days you have no incontinence episodes, it also can help with urinary incontinence as well. We would then refer you to a urologist or a radiologist to place a permanent device. So, when we think about incontinence, I think it's really important to, get a thorough history, make sure we do, a good workup, think about structural causes as well with the manometry. And then, ultimately, if we need to have a more invasive procedure, I think that's something that is very feasible, and it's really given a lot of people a good quality of life as well. All right, take care.